So if a patient has hyperthyroidism, they're going to have increased metabolic activity, and as a result, they're going to have, typically, if you touch their skin, warm and sweaty skin. They may have a history of weight loss. Cardiac output would be increased because of their increased heart rate and increased contractility. Obviously, tachycardia, increased heart rate. If they've had hyperthyroidism for a while, they may start noticing weakness, and that's because of the effects on skeletal muscle of breaking that down and freeing up protein. As far as the nervous system goes, if we were to test their reflexes, such as their patellar tendon reflex, or really any reflex, but that's one that we're very familiar with, these patients are often hyperreflexic. Again, hyperthyroidism affects the nervous system, and so an excess of thyroid hormone causes people to be irritable and likely have some insomnia. And because of the effects on the GI system, patients who are hyperthyroidism may have increased bowel movements or diarrhea. So some of the most common, some of the causes of hyperthyroidism, Graves' disease is a very common cause of hyperthyroidism, and we'll talk about that in a second. A hyperfunctioning nodule or a toxic adenoma may cause hyperthyroidism. And another interesting thing that we'll talk about is a pituitary tumor. That is a hyperfunctioning nodule within the pituitary that secretes excess TSH. So these are three different things that will give us a good understanding of some of the various ways that the thyroid can have problems. So let's look at Graves' disease. Here's our typical setup, again with our anterior pituitary releasing TSH, and that typically binds to the TSH receptor, resulting in the formation of our normal amounts of T3 and T4. Graves' disease is an autoimmune disease, and these patients create an antibody that's going to bind to the TSH receptor. So the problem with this is when this binds to the TSH receptor, it actually activates it. So in essence, it mimics the actions of TSH. So these patients with Graves' disease have excess antibodies which are going to be activating the TSH receptor, so that's going to cause an increase in T3 and T4. If you recall our feedback mechanisms, T3 and T4 is going to cause a decrease in TSH, but that's not going to change the production of T3 and T4 because it's being produced because of these autoantibodies stimulating these receptors. So in this case, patients with Graves' disease are going to have elevated T3 or T4, they're going to be hyperthyroid, and they're also going to have a goiter because of the stimulation of these TSH receptors. So these are a couple of pictures of what a patient with classic Graves' disease looks like. So you can see the enlarged thyroid gland, so they have a goiter, and kind of get a sense that both of these ladies are rather thin, perhaps appear to be a bit irritable. But one of the striking findings with these patients is this advanced eye disease that they have. And this is called Graves' ophthalmopathy. And these are striking examples. Doesn't necessarily get this bad. A new term which is being used to describe thyroid eye disease, or various types of thyroid eye disease, is called TED, or thyroid eye disease. How about a hyperfunctioning nodule of the thyroid? So this is a situation where we have a nodule which is autonomously functioning, meaning it's not going to respond to typical feedback mechanisms. So what I'm going to insert here, this is a picture of what we call a radioiodide scan of the thyroid gland. So if we give a patient iodide, it's going to concentrate in the thyroid gland, and we can put a scan over the patient and we can see a nice outline of their thyroid. In this case, though, we have a situation where we have a hyperfunctioning nodule. So this nodule has a mind of its own, and it's going to be producing excess amounts of T3 and T4. Now this in turn is going to cause a decrease in TSH. Now the way that this iodide scan can be useful is if we did this scan on this particular patient, what we're going to see is an increased uptake which correlates with where that nodule is located. So this nodule is taking up much of the iodine in order to produce T3 and T4, and so this is referred to as a hot nodule. So this patient will be hyperthyroid. Now we can also have a hyperfunctioning nodule in the pituitary gland. So in this case, the problem is that the nodule within the pituitary gland is producing too much TSH. This then results in overstimulation of the thyroid gland, resulting in hyperthyroidism or excess T3 and T4. So this patient would also have an attempt to feed back and inhibit further TSH, but because this is a hyperfunctioning nodule, the TSH is going to stay elevated. So these patients again will be hyperthyroid, and because of the excess stimulation of this trophic hormone TSH, they're also going to have a goiter.